Okay, I think we're about ready. Thank you for your patience. And again, thank you for being here. My name is Nicole Christensen, and today we're going to talk about the changes in community Medicaid. It seems ever changing. But again, I am also the president and founder of Care Answered. And Care Answered provides patient advocacy and healthcare coordination for older adults and their families. Our mission is to access the best care for our clients while giving their loved ones peace of mind. So we do a lot of work in a lot of spaces of transition of care, and community Medicaid is one of those spaces. So I'm also the author of the book From Crisis to Calm, which talks about how to navigate the healthcare system and coordinate care for any caregiver. So without further ado, because there's a lot to discuss, let's get started. So community Medicaid, what is it? You'll see there that it's standard. Community Medicaid is standard health insurance, right? And it allows people to remain in the community. Okay, so I'm just going to briefly talk about this. And for all those that know me, the numbers are not my specialty, but we definitely have people even on this webinar that can speak to it. But this is the basic limits, Medicaid eligibility limits for income and asset limits. So you can see there the numbers of a $934 a month, and this is for this year, 2022. And then you see the asset limit as 24,600. So I'm not going to be speaking a lot on the financial changes because a lot of them haven't taken place, but I am going to talk a little bit about it. So this is the basics of community Medicaid financially. Now, there's a lot of things people look at it and they say, oh my goodness, I'll never qualify. That is not the case. So don't think that. Don't tell your friends that for those that are clients or caregivers. But it is a basic, and then you can work with Medicaid specialists and elder law attorneys to help navigate you through so that you can do appropriate planning or appropriate things that may be, so that it may be an option for you. Okay, so I like to start with good news sometimes. And we have a little bit of good news. So the 30-month look back, you probably have heard about it. If you've been listening to me, you hear about it probably ad nauseum, or if you're in this world. So the 30-month look back, which talks about financials, right? So the same numbers that I just showed you, and they would look at it for 30 months. So if you transferred any kind of monies of any kind of substantial or even not so substantial, they look at that and say whether you're financially appropriate or if it would be delayed. Again, I'm not going big into that, but the good news is that it has been delayed. So they're not going to do that 30-month look back until at least March, I think it's actually 31st of 2024. So that's great. So we have a little more time. That doesn't mean delay your planning at all. It just means that we have a little bit more time. Okay. So now there's also something called the immediate need Medicaid application. I don't know how many of you are familiar with it, but it basically fast acts, in theory, your Medicaid application so things happen faster, so that potentially you're approved faster and getting the care faster. So currently, up until a few weeks from now, right, December 1st, the immediate need application was going through the same process that the care approval process that took place before May. And I'll talk about that a little bit just so that it makes sense to you. It's more expedited in comparison to what happens now. So there's only two assessments, and then they tell you right away the care hours that you'd be eligible for. So that immediate need Medicaid, as far as the care approval, stays the way it has always been till December 1st, as of my understanding, which was yesterday. There's still fights to make that longer so that immediate need could be more immediate, because without that way of approving the care, which again had only 2 assessments, it's going to be elongated. So there's a big fight and a push to keep it the way it is. But that's the news for right now. And we can talk more about that in a little bit. So some other good news is that there is an increase coming in income limits for community Medicaid starting in January of 2023, which that's very exciting. So if I cannot predict the exact numbers because it's potentially based on the federal poverty level, but for singles, it could go up to $1,563 a month from $934, which is pretty substantial. And that, again, when you're talking to your Medicaid specialist and your elder law attorneys, they can talk to you about what that would mean for the potential of pooled trusts, if it's necessary, when it would be recalculated later, if you're already on community Medicaid, and that kind of thing. There's also a slight increase in asset limits. You'll see that there on the screen. So for a single person, it increases from 16,800 to 28,134. Again, these asset limits are changing as of January of 2023. It's hard for me to say 2023. It doesn't sound right. It sounds like that's many years from now, but it isn't. So those are some good changes that can help people get the care that they need through community Medicaid. Okay, I have somebody that is not on mute. If you could all put yourself on mute. Okay, there we go. So community Medicaid eligibility. So how does this generally work? This is after you've been proven financially eligible, which we talked about briefly. So the general rule is you must need at least 120 days plus, right, of assistance with activities of daily living, right? So that's what makes it long term. Anything less than that, so for example, you break a leg, that's hopefully not going to be a long-term need. So it has to be long-term. And the NYIA assessments, these are now the 2 assessments done by the state through Maximus, determine if the person is approved medically for community Medicaid. And then after that, you select an MLTC. That MLTC provides an evaluation, and based heavily on the previous assessments, they will let you know how many hours of care you are approved for. So when I was talking about immediate need, only needing 2 assessments, that was generally the Maximus, and then the state of New York, and then the Department of Social Services, because that's who would do the assessment for immediate need. So now, and starting December 1st, for even immediate need, there are 3 assessments. And then we're going to go into that more deeply in a moment. So things that we should know about the approval process for medical approval. The 2 assessments that I talked about, the NYIA or New York Independent Assessment, they're actually by policy, have to be completed within 14 days of scheduling. 14 days of scheduling. So that was done for us so that it wouldn't be a more elongated process. What's the truth in the field? I've had to advocate that those indeed happen within 14 days. I've had people tell me that they had it months afterwards. I have experienced myself with a client that it was a month after the first assessment, the clinical assessment, the two assessments. As you see there, the community health assessment is by a nurse. There's one nurse, and then there's one clinical assessment. So one nurse assessment and one clinician assessment. And so after that, they tell you if you're medically approved. They don't, so it says there on the slide, which is wrong. So sorry about that the clinician assessment by an independent clinician who potentially determines the hours, it's not determined by the clinician. That's the way it was kind of written and that we thought it was, but it actually is still determined by the MLTC, who has to then do another assessment to tell you how many hours. Please write in chat, or you can come off if any of this is confusing, because it is by nature confusing, but I want to make it clear. And if the hours or the clinical assessment is concerned that that the person might need more than 12 hours of care a day, it can go to an independent panel to determine if it's safe, whatever that means, for the person to remain in the community. So I haven't myself seen that yet. Obviously, I'm an advocate, so I make sure everything is in place so that won't happen, but that's a very scary thought. I think what it's really pointing to is when I would have clients that had skilled nursing needs, so say they had a trach or something like that, that's going to point to that. And I think this is me, nobody in the state is really listening to me, sadly, but I think that is the way that they are trying to kind of get those people potentially off of community Medicaid. And I'm sad to say that, but that's what I think that 12 hours is really going to shine through. So how you present and how you advocate for the care is even more important than it's been before. The other thing that's new is that assessments will be done annually and are valid for 12 months. So those of us who've been doing this or had this experience before, we had the Maximus assessment that was good for, I think, 75 days. So these are good for 12 months. So that assessment that is done by NYA is good by the two assessments. So you have to, again, have the nurse assessment and then the clinician assessment. Those are good for 12 months, which does help some people because, we all had those situations before they came to me that they had it done and they couldn't make a decision and they had a lot going on and the 75 days ran over and they had to start the process again. So having it valid for 12 months can be helpful. Okay, so activities of daily living. A lot of what community Medicaid is based on is one's capability to do activities of daily living. Those of us who are in this field or have gone through it are probably aware that safety and supervision are generally not up for discussion as far as hours of care are concerned. So there was confusion, but it's pretty cleared up now that this new policy that I'm going to talk about is not going to take place until after April of 2023. So we don't know when. It could be 2 years after. If that's not clear yet, stay tuned for more updates. But what they were looking at as far as activities of daily living are ambulating or walking, personal hygiene. Oops. 1 second, I'm sorry. Okay, I'm going to have to ask you if you can hear me. If anybody's near a computer, can you let me know?
Yes, I can hear
I
you.
can hear
I
you.
can hear
Thank
you.
you. Thank you, thank you, thank you. It just said device disconnected, so I don't know, the satellites in the sky are not happy with me. Okay, so activities of daily living: ambulating, walking, personal hygiene, dressing, eating, bathing, transferring on and off toilet and toilet use, and turning and positioning in bed. That's these new activities of daily living that they're really looking at. The thing with that is there's good and bad things. One needs to require physical maneuvering with at least 3 of these ADLs. That means a person actually assisting you, hands-on assistance. But for those with dementia, they would need a minimum of supervision with 2 of those ADLs. So that is new. When it does happen, it is new because, as I mentioned before, when we speak safety and supervision, that's generally means you're not going to get care hours for it. So this is a switch because they're actually looking at folks that have dementia that may have great physical capabilities, but they need supervision with 1 or at least 2 of these activities. So supervision can mean, okay, they can dress, they can physically put their hands over their head and put their hands through a sweater, but somebody for this, they have to cue or to supervise because they may not recall how to do that. So that is a good thing because they are looking at supervision, but for those that have a diagnosis of dementia, so that's going to be very key. I know sometimes families have difficulty getting the actual diagnosis. It's something that's known, but they haven't actually gone to a neurologist or a doctor that's actually said it on paper. So that's going to be really important, especially, well, it's always important, but especially after these new rules change so that you can get that coverage. What it doesn't include on these lists of ADLs are incontinence when the person cannot use a toilet. So they have transferring when toileting, but not straight incontinence. So that'll be new. Transfers other than toilet use are also not necessarily looked at. Medication administration is not looked at. It's not, I shouldn't say that, it's not listed specifically. So there's a little worry that they won't be looking at it. And any IADLs, so managing finances, handling transportation, shopping, preparing meals, using telephone, managing medication, laundry, housework, those kinds of things that we're often asked are not specifically listed. Okay, so what's the changes in process? So it seems to me that the state is creating an assessment system that kind of takes MLTCs out mostly of the process, but not really, right? Because I said before, initially they had said it came across as if MLTCs would have no part of the process in determining hours, but they indeed are the folks that determine those hours. It's just now seemingly very heavily based on the assessments that are done by NYA. The primary care physician out of the process of prescribing CDPAP or personal care, so that's home care agency, or when you have somebody provide the care and you're the supervisor, somebody that doesn't, you know, that could be a neighbor, a family, a friend to provide the care. The independent doctor that they have now looking at it may have no understanding, like the clinician that comes in, they don't know, that does the assessment, they don't know that patient. It is not a patient of theirs. But I will let you know that there is a form to allow regular doctors to have input. And I have used different ways to make sure that their doctors are also
heard in the process. And I find that to be very important and helpful. Okay, so there also seems to be a push for dual eligibility programs, Medicaid, Medicare programs. So I just want to speak to that quickly because I don't think enough people understand what that is. So many of you that have worked in this system are probably aware of how it works. And a lot of people want MLTC, right? So they want they want to keep their regular insurance and their regular doctors, and they're just using the Community Medicaid program for care in their home. However, they're trying to push so that it's a Medicare Medicaid plan because that's honestly cheaper, right? So we know that Medicare is a federal, this is my feeling anyway, but this is true indeed, that Medicare is a federal program, right? And Medicaid for the most part is a state program. So if you have a combination, it doesn't fall so much on the state, to put it very simplistically. So there seems to be a push there. And I had somebody come to me as a client not too long ago that they didn't work with anybody, but they thought they were getting community Medicaid. And what happened was they had really great insurance. And what was selected for them was really a MAP program or a dual eligibility program. So if they didn't find out seconds before they enrolled, because fortunately the MLTC shared with them, okay, so you're going to lose your insurance. You know that this is a Medicaid, Medicare program. And then that halted everything, but they had no idea. So they were going for a program, but really had no idea that what it would lead to. And it halted their approval for a care because they couldn't use that program. And in addition, there is another form. So if you want to have your loved one be making these decisions for you, not just a healthcare proxy, but kind of a representative to speak to NYA or Maximus, you have to fill out this form. And it's very important in this case, because when they knew that they would have to change their insurance, and then I informed them it's because of this, that you were looking at an MLTC with a dual eligibility, and that's not what you want, to go and have another assessment with another MLTC through NYA, they had to have that person who actually had a dementia diagnosis state that they wanted that. And they weren't able to state that because of their diagnosis and the symptoms of it. And they wouldn't take a spouse or anybody else because they didn't fill out this form, but they didn't tell them that's why. So knowing this information, there's a lot to know, and it's very overwhelming for families, but we can help, but just know that these things are in play. Okay. So there is, in the dual eligibility, there is the PACE, which has an adult daycare. All services are on site by a managed by an insurance provider. So one of what we call the MLTCs. And then there's MAP Advantage, which is kind of like, if you're familiar with the Medicare Advantage program, it's similar. You can only use those providers that are under that umbrella, that insurance. So now for a while, this has been true. What's on this slide is the Consumer-Directed Personal Assistance Program. They don't have to inform people that it exists. Again, that's the program in which you can have a family member, friend, neighbor, somebody that doesn't come directly through a home care agency provide the care, and either the person, the member that has the community Medicaid, or their healthcare proxy or loved one can be the supervisor or POA. So there's supposedly they didn't have to inform, but I feel like in the current circumstances, due to worker shortages in everywhere, but in particular in home care. They are really, in my experience, are really informing people because for some people, that's probably the easiest way, if you have access to that, to get care in the home. But unfortunately, a lot of people don't have access to loved ones and neighbors and friends who could provide that kind of care. And then the MLTC lockdown. Again, this started December of 2020. So it was the ability to transfer to another MLTC plan. So for the first 90 days, if you say, I don't like this MLTC plan, I'm switching, you're free to do that. Then after those 90 days, you can no longer change your MLTC plan for at least 9 months, so a full year from when you started. However, they can change from MLTC to or from a PACE or a MAP program. That's what the programs, that the dual eligibility programs that we just discussed. Okay, steps to take. Elder law, speak to an elder law special needs attorney now to plan appropriately, a Medicaid specialist to get things going. Do not wait, because we're all kind of not knowing what's coming next. So you don't want to wait. You never want to wait to plan. I know what that's like, and I help people that are in that situation, but it's so much easier if you take the time to plan now. It's a peace of mind that you don't even know you get until you start doing it. It's just something you don't have to think about it. The other thing is the nursing home, NHTW, Nursing Home Transitional Waiver Program, and the Traumatic Brain Injury Waiver Programs are not affected by these changes. So for those that don't know, the Nursing Home Transitional Waiver Program is especially good, I find, for folks that are at home, maybe, and they need more supervision. So maybe it is somebody that has a diagnosis of dementia or blindness. This program is a waiver program to keep people out of nursing homes and in the community if that's what they wish. So people get a little concerned, I know, when they hear the word nursing home, but it is really to help people stay in the community. So they're not affected by these changes, the changes that will happen supposedly in March of 2024, or it seems these care approval changes. Also, what I would say steps to take is that look to an advocate now to access the best care that you need, because there's a lot of misinformation out there, and you want to be able to have, the more you plan, the more you talk to a professional, the more options you may have. When you take time and you don't do that, then your options become limited, and it's very sad and not necessarily necessary. So I'd be happy to talk to you, and look to us for continuing updates, because as I said, this is a moving target, and changes happen all the time. So I'm going to check this chat to see. Yes, Barbara, I will be sending the replay, which will have the same slides in it. Thank you for asking. You guys can take yourself off mute or put any questions in the chat. Wow, guys, I'm impressed. That was a lot of
Nicole,
information.
I have a
Yes.
question. Nicole,
Yeah, absolutely.
what we have been kind of seeing with these assessments is a lot of people hours are like 2 hours, 7 days a week. Like they're really cutting these hours. Like prior to it was like, minimum would be 4 hours, 7 days a week, maximum 24/7. We're now seeing out there like 2 hours, 7 days a week. It's like, how are they coming up with these, and how are aides even going to a home for 2 hours, like to even get staff to cover them?
That is an excellent question, Linda. So I have heard that very same thing. I have not experienced that because again, I advocate for the most hours possible that they need. But yeah, that sounds crazy to me. I don't understand. They're not going to find, I mean, I'm just going to put it from my experience and understanding. They're not going to find an aide unless it's CDPAP. I don't know anybody that is going even through all of the hoopla or the hoops of community Medicaid to get 2 hours a week.
Right.
That must be extremely disappointing, if not devastating.
Mhm.
So there's a lot of things that can be done. And, you know, even at Care Answered, what we do a lot is assessments before people even apply, because we want people to have realistic expectations of the care they may get. And again, I still have not met a solitary person in which I've done that assessment for and said, oh, you might get 2 hours once a week. Because I there's just nobody that I've met so far that would do that. But I would be perfectly able to tell somebody that they're not going to get any hours or they're going to get very low hours. But again, I had maybe one client that had that really the only thing was safety and supervision, and I was concerned. And I told them because I had heard the same thing that you had heard, Linda. And I said it might not be the best thing to apply. And we went over for their other choices and options for care. But yeah, your guess is as good as mine as how they're getting people to even come and do those hours, unless it's somebody that they love, or you know, a neighbor or a friend, or somebody in their congregation doing it.
And just one other question. So in that situation, what's still on the talk of the town is that the recommendation is that the family accept the hours and then fight it after, right? Go into the program, and then fight for more hours once they're in the program. Any thoughts on that? Is that the way to go?
Yeah, I would say in this current situation, and this is not to toot the Care Answered horn, but I really believe that people need an advocate early, like more than ever. Because again, what you're saying about these hours are just, it's crazy. It's crazy. So if they need more preparation beforehand, because they don't know what to say. They don't know how to state it. And so if it's a time issue, I'm not against that, right? So if it's a time issue, I can certainly go in and appeal that and likely win. But there's some folks that just need the prep beforehand, because the kind of the emotional toll, nevertheless the financial toll of going through that and then hearing 1.5 hours or 2 hours a week, that's really harsh. So I would like if people came to me, I did an assessment so that I can tell them that. Again, I haven't had a real issue with that before, of saying of stating that, except for that one case. But yeah. But if it's a time thing and it's already done, yeah, don't wait, get on it now. But it might be best for them to get the help beforehand even. Oh, somebody said we just
Thank you.
recently. Did that answer the question, Linda? I'm sorry.
You did.
Okay. All right. Just recently, we had a client with dementia approved for 1.5 hours a day. They had an advocate there with them also and were evaluated before them. I don't know what to say. I don't know what to say. It again, if it's if they have dementia, I say only dementia, that's not a thing. But if their only diagnosis is dementia and they're able to do everything for themselves, this might not be, and again, I haven't met that many people in that situation, because when I dive into it, other things become clear to me anyway. So, but if it really looks like that, then they're not going to get much care. If they're saying that basically they need safety and supervision, they're not going to get many hours of care. But that's always been the case. In addition, you have to watch yourselves, because when that happens, I've heard some people have, they wander, they need safety and supervision. Those are kinds of things they don't cover, but they can say you have to have somebody with them. So that is a very scary thought, to say, okay, we've been making it this far, and now we got 1.5 hours, and they're telling us that now we have to basically pay out of pocket or stop working or what have you, and have somebody with that person for 24 hours. These are kind of nightmare scenarios, I know, but they happen apparently very often to people without an advocate. So it's important that everybody kind of knows what they're getting into, so that they can be prepared, because I would hate for somebody to get such low hours and then be told, by the way, you need to have them 24/7, because we know that they need that supervision. We just don't cover it. Did that answer your question, Christina? I hope so. Any other questions? These are great questions. Thank you. And it's always good to, share what we're seeing, because I think that that's very helpful for everybody. So thank you very much for your input. Okay. Well, thank you all again for being here. I so appreciate you. And again, stay tuned. And we'll see you next time at the next webinar. The next one will be in January. So happy holidays to everyone.
So Nicole, I have
Yes.
a question.
Sure.
I know you said earlier that you don't talk about numbers, but I'm interested in the you said pool trust.
Pooled trust.
Yeah, if our income it's higher than the allowable amount.
Yeah, there are a lot of people. That's a really good question. I don't feel comfortable like telling you all the details, of course, but I will definitely send you some names that you can
Go to
and numbers that you can go to get the answers to those questions. Some of them are on this call.
I believe you have my email address.
I do. So I will send that out to you.
Thank you so much, Nicole.
Of course. Thank you.
So the information you're giving us is for New York State, and the number you're gonna provide to me is someone close by in New York City, yes?
Sure. You're in New York City?
Yes.
Okay. Yep. I'll
Thank
give you information for folks in New York City that you can speak to, but the information is it is state by state. I mean, it's for the entire state.
Okay, great. Thank you so much, Nicole. Thank you.
You're welcome. You're welcome. Take care, everybody.
Thank you for this information. It's very helpful. Take
I'm
care.
glad.
Yeah.
Thank you.
Take care.